targeted therapy for unresectable EGFR-positive non-small cell and future perspectives. So these are my disclosures. And I think what I want to talk about today is a short history and the current standard of care for unresectable EGFR-positive stage III non-small cell lung cancer. And I think what's a very interesting question is, can we make unresectable resectable? I think we also should discuss the role of radiotherapy in unresectable EGFR-positive stage III, and shouldn't we maybe even treat the really unresectable stage III non-small cell the same as metastatic EGFR-positive non-small cell? So one step back, what is unresectable? And I think that's quite difficult because there is no clear definition provided in clinical trials, and it really depends on the multidisciplinary team, the an MDT, then this can improve the treatment selection as well as outcomes. So these are a couple of Mayer curves from the ELCC. It's not being published yet, but it was shown that if the patient was discussed in an MDT, then both event-free survival and overall survival, if the treatment was MDT adherent, improved. And of course, there can be biases, but I think this message is still there. You really should discuss patients in an MDT. So again, coming back to the question, what is unresectable stage III? There is no uniform definition. So there was a small IASLC survey a couple of years ago, and they asked, what's your preferred treatment for stage III, so 3A, 3B, or 3C non-small cell lung cancer? And you can see that there was, except for 3C, no clear consensus whether this should be chemoradiation, surgery, or even trimodality therapy. And on the right, you see a survey on stage III and II, the practice for each country. And you can see that it really differs whether it should be surgery, chemoradiotherapy, multimodality, etc. So I think still lots of discussion, and it also makes it difficult to compare clinical trials because often you don't know which patients were actually included. And resectability really depends on who you ask. So this is an EORTC survey presented at World Lung 2 years ago. The manuscript is submitted. So if you look at all respondents, then in general, the N2 bulky, N2 invasive, and maybe the N2 multi-disease with T4 invasion or satellites were considered unresectable. But if you look at the thoracic surgeons, especially the resectable parts, they stated for more diseases that it was resectable. So you see less question marks on the table on the left lower bottom. This, in the end, within the EORTC, within Europe, we had a consensus group. And in the end, through a Delphi process, so a systematic review, the survey I showed you in the previous slide, cases and multiple discussions, we came up with this proposal. But I think it's important to note that this is really upfront resectability. So if you give induction therapy, then I think in the end you can make some of these non-resectable or potentially resectable cases resectable. But that's not really studied in clinical trials at the moment. But I think trials are ongoing and some phase 2 trials have been reported. I think also important to consider, and please keep this in mind for the remaining of the presentation, it was stated that the mandatory workup should consist of at least a contrast-enhanced CT scan, an FDG PET scan, brain imaging, preferably an MRI, invasive mediastinal or nodal staging, so ES, EBUS, with or without a mediastinoscopy, and depending on the suspicion of invasion in the neighboring structures, also additional tests. And very important, you should, again, as I stated, not do this on your own. You should involve a thoracic surgeon, an experienced one, a radiation oncologist, a medical oncologist, or pneumo-oncologist, depending on who is giving the systemic therapy in your hospital, the pulmonologist for the pulmonary function, imaging specialist, and the pathologist. And in the end, the final decision is made in the MDT. And if you then go back on the evolution of the treatment for patients with unresectable stage III, and again, in the majority of these trials, it was left up to the local PI to say what was unresectable, then you can see that in the 1980s, with radiotherapy only, the 2-year overall survival was only 18%. Then sequential chemoradiotherapy, if you compared it with radiotherapy, then the 5-year overall survival was 17%, but the absolute percentage did not improve, probably due to different patient population included in these trials. Then 5 years later, concurrent chemoradiotherapy, the 5-year overall survival 16%. Then we did lots of clinical trials with other chemotherapy regimens, maintenance therapy, induction therapy, consolidation therapy, and to be short, they just did not improve the survival. In the RTOG 716 trial, if you give more radiotherapy, a higher dose, benefit did not improve, and also no benefit of adding cetuximab. But if you look at the 5-year overall survival in 2020 compared with 2011, it almost doubled. And I think that's also due to better staging, better treatment, and better supportive care. And in the end, we have, of course, you all know the Pacific. For now, adjuvant durvalumab is the new standard of care after chemoradiotherapy, resulting in a 5-year overall survival of 43%. Also important to know in daily clinical practice, more than 40% of patients with unresectable stage 3 is not eligible for concurrent chemoradiotherapy. So these clinical trials are really a selection. So based on these clinical trials, what is in the guidelines? So if you look in the ASCO guideline, then it's stated if a patient who is medically or surgically inoperable, so think again back to the data I showed you, there was discussion about this. And if the patient had a good performance status, then it's concurrent chemoradiotherapy. If there is no disease progression, then adjuvant durvalumab if there is no classical activating EGFR mutation. Because if there is an EGFR mutation, then now the newest update of ASCO incorporates consolidation osimertinib. ESMO has a really old guideline. The new one is currently submitted but not published yet. So looking at the data the guideline is based on, I think you all know the Pacific. So unresectable stage 3, no disease progression after chemoradiotherapy, good performance status after within 42 days of completing the radiotherapy, and then patients were randomized to durvalumab or placebo. Again, unresectable, loosely defined and based on the size criteria. And then you can see that primary endpoints, progression-free survival on the lower bottom in the Kaplan-Meier and overall survival, a clear benefit of adding adjuvant durvalumab. But it's also important to realize that even with adjuvant durvalumab, the 5-year progression-free survival is only 33%. So lots of these patients do not benefit. And I think also important for this trial, multiple patients were screened, but 270 patients were not randomized because in the end, they were not eligible within the specified time frame. So again, a huge selection. If you then move to the topic of today, so the EGFR mutant subgroup, we have the post-hoc Pacific analysis. Approximately 5% of these patients had an EGFR mutation. And if you then look at PFS or OS curves, and of course this is exploratory, then these patients did not derive any benefit from adjuvant durvalumab. And I think this is also what you expected based on the metastatic disease setting. In general, these patients do not benefit from immunotherapy, especially not single-agent immunotherapy. And I think, as you're all very aware, EGFR TKI toxicity can occur after immunotherapy. Immunotherapy has a long half-life, and one phase 2 trial evaluated pembrolizumab first line in EGFR positive non-small cell. Well, no responses, as you could have guessed, but lots of hepatitis and pneumonitis from subsequent TKI. So again, please don't do this, test these patients and don't start immunotherapy. And it's also known that EGFR positive non-small cell is not immunogenic, and we need to treat these patients differently. So these patients have a low tumor mutational burden, low or no intermediate of PD-L1 expression, and limited T cell infiltration. And also in a metastatic disease, and here I showed you the meta-analysis from immunotherapy compared with docetaxel, these patients just don't benefit. So we need to do something different. And I think the first trial we had was the LAURA trial, besides the POLSTAR trial. So LAURA is lifelong osimertinib after chemoradiotherapy. Little bit different design compared with Pacific. So again, unresectable stage 3, no progression after chemoradiotherapy, but also sequential chemoradiotherapy was allowed. And these patients received osimertinib or placebo. And the endpoints, the primary endpoint was progression-free survival and key secondary overall survival and CNS PFS. Again, PET staging was not mandatory, and on retrospective central review of the brain imaging, 10% had baseline brain metastasis. So I think this is again a signal that these patients are a different patient population. So if you look at the PFS curves, I think a clear benefit. Osimertinib median PFS 39 months, placebo below 6 months, so also lower than what was reported for the Pacific EGFR positive subgroup, but the trial was really positive for the primary endpoint. So if you then think, okay, why was this PFS so limited compared with the Pacific data? Is this undetected stage 4? Well, approximately half of the patients had no FDG PET at staging. But if you look at the PFS hazard ratio as well as the median PFS, they are similar for PET versus no PET. So it doesn't seem to be really the cause that it is understaging that these patients do worse. So I think this raises the question, is EGFR positive really unresectable stage 3? Or is it maybe the same as stage 4, and shouldn't you treat this as metastatic non-small cell? If you look at progression patterns, well, we all know that osimertinib had good CNS penetration, and you can also see it on the left part. The CNS PFS is clearly better for osimertinib than placebo. And I think this is also something to take into account. Preventing brain metastasis is important for patients. And if you look at the types of progression, then you see that even with the chemoradiotherapy, 20% of these patients had local progression. So something also with the radiotherapy is maybe not really working in these patients. We only have an interim analysis for overall survival, so 31% maturity. It looks that these curves are now splitting with longer follow-up, but the data is really immature. And I think especially for EGFR positive disease, because we have good systemic therapies, if these patients progress, we should look at the subsequent treatment lines. So 73% of the patients treated with OSI, 87% of those treated with placebo, started a new therapy if they had progression. OSI, quite a lot of radiotherapy, so 1/3 of the patients. So that raises the questions, was this oligo progression? Fortunately, 3/4 of the patient got OSI therapy in the placebo arm, and 1/3 of the patients got chemotherapy in the OSI arm. I think the jury is still out whether LAURA will be, in the end, be positive for overall survival. I think there is a risk of toxicity, but there is also a real benefit for PFS and CNS control, and maybe for overall survival. But we have another study. We have the POLSTAR study. So quite similar design, lifelong aumolertinib after chemoradiotherapy. Similar design as the LAURA trial, only the stratification factors were slightly different and the same primary endpoint. And again, I think you can almost interpose these Kaplan-Meier curves on top of each other. Median progression-free survival quite similar for aumolertinib and placebo than osimertinib and placebo. I think the main differences is in POLSTAR, more patients got sequential chemoradiotherapy, so a slightly different patient population. POLSTAR was China only, LAURA, 81% of patients were Asian. POLSTAR, a little bit less EGFR exon 19 deletion compared with the L858R, and less patients with a good performance status. So this can also explain some of the small differences in PFS seen with aumolertinib. If you then look at the patterns of progression and the OS data, I think in summary, this is quite similar if you compare POLSTAR and LAURA. Still some local relapses with aumolertinib, and CNS is a problem if you don't give EGFR TKI. And I did not put the safety data here, but it's quite similar for both drugs. So I think maybe also a question is, can we make unresectable resectable? So this is, I think, a very interesting study just published in Nature Communications. Single arm phase 2 study, 16 weeks of neoadjuvant aumolertinib, 56 patients. And I think it's important that they really published a definition of unresectable. And in the end, it was stated, well, primary tumor or metastatic lymph nodes invading in vital structures, so they are unresectable. Mediastinal lymph nodes with multi-station metastasis or bulky fusion, or N3 metastasis. So I think this is really mirroring the EORTC proposed definition. So these are patients that in general are not operated on in most MDTs. And if you then look at the figure, then 51 patients in the end got neoadjuvant aumolertinib. 36 had a partial response, and 23% of these patients became resectable, and all had an R0 resection. So approximately half, just below half of these patients, if you select them correctly, you can make resectable. I think we need larger clinical trials, but I think this is a very good start to see whether you can do something for these patients. If you then look at the responses, then you can see on the figure on the left, indeed, very nice responses. Only one patient with really no shrinkage of the tumor, and the majority got a RECIST response. And this was across stages for all mutations and regardless of smoking history. Pathological response was a little bit lower. You can see that the majority of these patients did not reach a pathological complete response or major pathological response. So I think for me, this is the message, is mainly to make something that's unresectable or borderline resectable. But I have some doubts whether you really can increase pathological complete response or major pathological response with these treatments. So I think multiple challenges remain in unresectable stage 3. I think we still need new strategies to improve survival. Still some questions, I think, for re-challenge if you don't give these patients lifelong an EGFR TKI. The best treatment at progression, taking into account resistance mechanisms and locations of progression. These clinical trials mainly included patients with a good performance status and the younger patients, so we also should evaluate for the other patients what's the best treatment. Predictive biomarkers are still needed, new strategies, treatment duration, etc. And also important, we really need to reduce toxicity for those with increased risk of toxicity. It's less an issue in EGFR positive disease than in the overall unresectable stage 3 patient population, but also within the EGFR positive patient population, we have those with cardiopulmonary comorbidities, autoimmune disorders, frail patients, elderly, etc. So we really should evaluate how to approach this. So which treatment is the best for unresectable stage 3? I think I showed you not all patients truly benefit from EGFR TKI. Some are cured after chemoradiotherapy, but this is really a minority of patients, and some will not truly benefit from EGFR TKI. I also showed you not all patients benefit from radiotherapy or chemoradiotherapy. If you look at the poor PFS in LAURA and POLSTAR, the placebo or observation arms. So I think is stage 3 non-small cell actually micrometastatic stage 4? And do we need the radiotherapy? And EGFR TKI are expensive, so can we save costs? And for the remaining of my presentation, I will talk about these questions. So I think, are there patients who don't benefit from adjuvant TKI? We don't have these data, I think, for the unresectable EGFR positive, but we do have some data for resectable EGFR positive non-small cell. And based on a specific score, based on RB1 loss, CDK4, TP53, MYC copy number gain, etc., it is suggested that there are patients with a certain profile that are highly TKI preferable, and some patients maybe should got chemotherapy and no TKI. Other potential biomarkers are the true signature and TP53. So maybe we can also use these biomarkers to select for adjuvant TKI in the unresectable stage 3. And I think we also should look at the currently ongoing trials from the metastatic setting. And I put some examples here that are really evaluating the best treatment strategy according to the co-mutation. Also very important, some patients maybe do not need adjuvant treatment. So this is for immunotherapy. And it is shown that patients with ctDNA detectable post-chemoradiotherapy do benefit from adjuvant immunotherapy, while it is suggested if they are ctDNA negative that they don't benefit. So far, I think it's costly, a lack of sensitivity, and it's all small trials, but trials are ongoing also in the EGFR positive space to evaluate these things. We know from ADARA, so again, the resected EGFR positive non-small cell, that only 8% were MRD positive at baseline. That is, I think, at the moment quite difficult to predict which patient really needs adjuvant TKI. But it's important to see that especially the higher disease stages have more ctDNA detectable. So maybe if we look at these patterns in the unresectable space, we can tease out a signal to see whether these patients are really need EGFR TKI. And I think the other question is, what does radiotherapy add in unresectable EGFR positive non-small cell? So here the LARA example. So if you just look at the chemoradiotherapy arm, the Kaplan-Meier in blue on the left, then I think these patients have a really poor performance. So I think you can argue whether chemo and radiotherapy is the best treatment for these patients. If you look at the toxicity, then there is still quite some toxicity with chemoradiotherapy, so the radiation pneumonitis. And if you look at the patterns of progression, then quite some patients had local progression. So I think without EGFR TKI, almost all patients have a disease relapse within 2 years. So did the radiotherapy really do something? These patients can get the radiation pneumonitis and you have the local relapses. So shouldn't we treat these patients maybe like the metastatic disease? A sidestep, can we reduce costs? So lifelong osimertinib or aumolertinib is quite expensive. So we have some trials ongoing in the Netherlands, but I understood also in Singapore to give osi every other day. Or can we boost osimertinib with cobicistat, a CYP3A4 inhibitor, which is very cheap, to boost the plasma level of osimertinib to see whether we can give less osimertinib. So these trials are ongoing in the stage 4 space. And if positive, I think we should try to see whether we can extrapolate to the non-metastatic stage. So what I just also hinted on, so shouldn't we just start with upfront systemic therapy and adapt based on imaging, because these patients don't really benefit from the radiotherapy? So, and can we look at the metastatic stage? So these are the ASCO and ESMO guidelines. And I think in general, the aims of these treatments are improve PFS, but OS, control the CNS, maintain or improve quality of life, and limit the patient burden. And the consensus is, I think, that a third generation TKI, with or without chemo or with or without amivantamab, is preferred. And in the end, you can have a really interesting long-term survival with these treatments without radiotherapy. Here you see the details from these treatments. So in general, I think the third generation TKIs are quite comparable and all have good CNS control. So for the question, shouldn't we start with upfront systemic therapy and add radiotherapy at response? Can we learn from the metastatic stage? So I have here the overall survival curves from the FLAURA2, and the MARIPOSA. There is one clinical trial randomized evaluating patients with EGFR positive non-small cell and oligo-organ, so not oligometastatic, but oligo-organ metastatic non-small cell. And if you add thoracic radiotherapy to icotinib in patients without disease progression, then it is suggested that these patients benefit from adding thoracic radiotherapy. So I think it is something that you can consider, especially with the more contemporary regimens, so FLAURA or FLAURA2. And we need new clinical trials to evaluate whether we can do this in the metastatic stage. But I think this is also something to extrapolate to the unresectable stage 3, because as I showed you, most of these patients really have micrometastatic stage 4, I think. So my conclusions and take-home messages. I think the definition of unresectable stage 3 varies across trials. Adequate staging is necessary and is often not performed in clinical trials. Patients with EGFR-mutated non-small cell do not benefit from adjuvant immunotherapy. And both LARA and POLSTAR showed significant PFS benefit and CNS control. I think the question is still out whether overall survival will be positive. And I think so far is really shared decision-making with the patient. Can we select patients for adjuvant EGFR TKI based on molecular residual disease or molecular profile? And trials are ongoing mainly in the metastatic setting, but maybe we can extrapolate. And small trials suggest we can make unresectable resectable. And I think there is still doubt whether radiotherapy is beneficial for the majority of stage 3 patients, and trials are needed with upfront systemic therapy and local therapy adapted based on the response. And with this, I would like to thank you.